Research demonstrates that females are 3 to 6 times more likely to experience an ACL injury compared to their male counterparts. And this kind of leads us to the question then, are females innately more fragile? Or are we just more susceptible to this type of injury? In our past presentation, we discussed the very weak causal relationship between ACL injuries and female anatomy. Today, we're going to dive in to the very complex research that is available on female sex hormones and ACL injuries. So first, let's talk about what we do know. We know that 80% of ACL injuries are non-contact and therefore have been shown to be overuse injuries in both male and female populations. These injuries are typically experienced during deceleration, lateral pivoting, or landing tasks. Often we find that these movements are kind of like the straw that broke the camel's back when we consider what an overuse injury actually is. We also know that high knee loading tasks in sport occur at very similar levels between both genders. And we know that there is an increased risk for females getting these ACL injuries at around 13 to 14 years old, when females begin to markedly differ in hormonal secretion because of puberty. So what are the differences between male and female athletes? Well, there's those anatomy differences, which we discussed in the past presentation. And this leads us then to think, well, if it's not anatomy, is it our hormones, right? Because that's something that's going to markedly differ between the sexes, especially during puberty. In the past, what researchers believed is that, okay, during puberty, females' hips are getting wider, and this is what's increasing these quote-unquote Q angles, and that's increasing the chances of valgus. What we now understand is that valgus is more of a signal than a cause, and is a signal that there is really lacking neuromuscular control. But that also then leads us to question, okay, are female hormones changing the integrity of the ACL ligament? And is this why so many more females are experiencing ACL injuries? And is there possibly a relationship between when these injuries are occurring and where a female is at in her menstrual cycle? So before we really dive in, we have to understand something up front, and that sex hormones are extremely complex. And this presentation is not to get into the nitty-gritty of sex hormones. That is a rabbit hole for somebody else, like Victoria Felker, that is way more versed and able to explain and talk about this stuff at a much deeper level than I am. But we are going to kind of talk about some of the basic stuff that we need to understand when it comes to sex hormones and how these hormones are understood when we look at research. So firstly, sex hormones are cyclical, right? And the cyclical nature of these hormones are going to vary from athlete to athlete, from period to period. And that really makes it difficult to establish a baseline or control for studies on what normal hormone cycles are and how that may correlate to injury. I mean, look at the two graphs that I have presented on this PowerPoint, in that you see that the first graph kind of demonstrates what the idealized 28-day cycle is, and that certain peaks of hormones are going to help us demonstrate or distinguish during what phase of the menstrual cycle a female is in. So we're going to see a peak of estrogen, and that's going to be in our follicular stage. From then, that's going to lead into a spike in luteinizing hormone when a female is ovulating. And then from there, when we get into the luteal phase, we're going to see that there is a peak in progesterone and then a smaller peak in estrogen. But if you look at the graphs underneath, you see that there are 4 graphs of 4 normal ovulating females, and that these peaks do not correspond directly to what is idealized. But these women are still ovulating and still healthy, and these are still normal, healthy menstrual cycles. And this still helps us understand that just because we may think we know where a female is at in her menstrual cycle, it doesn't mean that she's actually in that phase. And that helps us understand that a lot of our current research is flawed, and that especially in prior research, a lot of the times we would delineate where a female is at in her menstrual cycle based on self-recall, and that we would say, oh, hey, when was your last menstrual cycle? And then from there decide, okay, she tore her ACL during the follicular stage. But do we actually know if she was in that stage? Because a lot of these studies didn't actually do any type of urinary testing to see, hormonal metabolites to see where she was at in her menstrual cycle. And that's something that we also need to understand, that just because one study said this and another study showed that, the methods in which we went to determining where a female is at were not the same. Another thing that leads to flaws in our current research is that sometimes research would be done on females, but she may have an irregular menstrual cycle. She may be anovulatory. That means that she's not ovulating. And that in itself is going to say that the cyclical nature of her hormones is going to be severely different than a female that is ovulating. And oftentimes we would still include those females in this research, and that is going to change the results. Also, what about, is this athlete on an oral contraceptive? What type of oral contraceptive? And we also need to remember that hormones are affected by life. Emotional stress, dietary stress, pain, all of these things are going to play a part in what's occurring at the hormonal level. And these things are really essential to understand when we think about, okay, do we actually, just because a research paper said this, what do we actually know? Is this research flawed? And this is just something that we want to keep in the back of our heads as we continue down this rabbit hole. Okay, so from some of our current research, we know that female sex hormones have the potential to impact the structure of the ACL, and that some of these hormones are going to affect collagen metabolism, ligament remodeling, the structural integrity of our ligaments. And this kind of leads us to believe, well, then of course hormones are the culprit, right? Because females have higher levels of estrogen compared to men, and we know this hormone is going to affect collagen metabolism and ligament laxity, and we know that knee laxity is going to increase the chance of a knee injury, and therefore this is the cut and dry cause. But we have to kind of get away from this black and white thinking, and we need to start to think, okay, so do sex hormones then make females inherently weaker? And then from there, how we've not evolved in such a manner that has kind of worked out of that, and then how have females as a population been able to sustain for millions of years? Does just being female put her at a higher risk? We have to understand it's not that complex. It's not that black and white. Remember, hormones are complex. They're just one part of a very larger system. So let's talk about what anterior knee laxity actually is. So before puberty, the laxity of the knee is pretty much the same on average between boys and girls. But when athletes mature during and after puberty, females generally maintain a higher laxity when this is going to decrease in males. So this means on average, women have a greater movement range than men throughout their athletic career. But the words in general should really be a red flag, in that women have a huge degree of variance, right, for person to person. And to complicate this even more, not all women have greater knee laxity than men. But what we do know is that female athletes experience constant changes in knee laxity. Laxity is greater on average in the periovulatory days of a cycle, think high hormone, and to a lesser extent in the mid-luteal days. These changes were observed on average 3 to 4 days following changes in sex hormone concentrations. Even more, these changes were more pronounced in females who had lower minimum estrogen and higher minimum progesterone concentrations. So why is this important? Well, 2 things. 1, greater knee laxity equals higher injury risks. Those who experience greater acute increases in knee laxity are more likely to move towards higher risk biomechanics when knee laxity is increased. basically, if your baseline knee laxity is already high and you enter into certain parts of your cycle, it's believed that it may increase knee laxity even more. And that makes you at an even higher risk because your body is more likely to have maybe some knee stiffness in landing, greater dynamic knee movement, and forces during landing and cutting. But again, we're gonna remember one of our main points here is that not all women have greater knee laxity than men. So can we say with complete absolute, oh, hey, this is why females are tearing their ACLs at a higher rate? Okay, so number two, we have to understand is that if your baseline hormones are altered because of taking a hormonal contraceptive, you could also be at a higher risk. Increasing estradiol concentrations have the potential to influence collagen synthesis and ligament integrity in a dose-dependent and negative manner. Last I checked, there are not a lot of male athletes that are using hormonal contraceptives, and if hormones, our own and those we put into our bodies with oral contraceptives, play a big role in how your body builds and maintains soft tissue, especially during puberty, when the female is kind of developing tissues and bone mass. So you see hormones, particularly estrogen, play a direct role in soft tissue metabolic activity. And this is important to understand. This is extremely important because on average, higher levels of estrogen are associated with a decrease in collagen, decrease in protein, and decrease in fiber diameter and density. These effects may be temporary, only lasting during certain parts of the period, but they are also super important when we start talking about ACL injuries in women versus men. And this is important because collagen is the main load-bearing structure of the ACL ligament. Evidence suggests sex hormones can influence your collagen metabolism and the structural integrity of your ACL. So that makes sense, right? Especially because receptors for these sex hormones are apparent on the ACL and in a higher concentration in females. But that also makes you stop and think, okay, are there more amount of receptors because there's a higher concentration of hormone, and that the hormone can't really be effective unless it's recepted? And is that why there's a higher amount of receptors? That's another thing that we have to stop and think about, that not everything is cut and dry, black and white, like we once believed. Okay, so let's talk about relaxin. Those of us who have never been pregnant probably haven't really heard much about relaxin, really outside of your 7th grade health class. That's because it's primarily considered a pregnancy hormone. Its job is to relax the pelvic floor in preparation for labor. But even if you aren't pregnant, relaxin is still going to be present in the body, and its receptors, they're on the ACL too. Females tend to have a higher number of relaxin receptors on their ACL compared to males, and young females show higher amounts compared to adult females. Okay, important to know, but again, we don't know why. Could it be because there is a greater amount of hormones, and when the hormone is greater, the amount of receptors will be greater as well, especially as you get older. We know menopause, all those fun things, your hormone levels are going to decrease. And is that why that there is a lesser amount of receptors? We don't know, but something to consider. With this higher presence, scientists have postulated that higher serum concentrations of relaxin are responsible for the greater incidence of ACL injuries in female athletes. But in a retrospective study in 2011, Division I female athletes who suffered an ACL injury revealed 3 times higher levels of relaxin, as well as more cyclical variability throughout their cycle. Other retrospective work has indicated that both serum relaxin and knee laxity levels were significantly higher in females with a history of ACL injuries compared to their control. So this sounds convincing, right? Relaxin's got to be the culprit. But here's the thing. These studies completely ignore how relaxin levels fluctuate during the menstrual cycle and how these fluctuations are affected by menstrual irregularities. This is a critical factor in females as almost 50% of exercising females experience some type of menstrual and therefore hormonal irregularities. In a study performed on females who were regularly menstruating within a 21 to 35 day cycle, there was actually no difference observed between mean relaxin levels compared to male counterparts. And although significant variances were observed over a 4-week period, there was no significant difference in knee laxity measured by anterior translation. So is relaxin actually the culprit? Well, we need to understand that sex hormones do not act alone. In a meta-analysis performed in 2006, 6 out of 9 studies on female athletes reported no significant effect of the menstrual cycle on ACL laxity. Even more, the majority of these studies that did find a relationship between the menstrual cycle and ACL laxity based their findings on a single day sample of the cycle without any hormonal confirmation. This approach makes the assumption that all days within a cycle represent an equitable hormonal environment. Now, we know that hormones fluctuate, so can we really trust the validity of that type of research? No, because here's the thing. Estrogen and relaxin do not act alone. They're a part of a much greater system. And this potentially disastrous effect of estrogen on soft tissue metabolism is attenuated when progesterone or testosterone are present. And guess what? Testosterone and progesterone are also fluctuate within the menstrual cycle, along with estrogen and relaxin. And these fluctuations can be different. So does that mean that a female is at a higher risk of injury during certain phases of her cycle? Or maybe would controlling that cycle through hormonal contraceptives help reduce the risk? There's 3 questions that we really need to ask when we try to understand what's really behind these ACL injuries in female athletes. The first is an athlete at a greater risk for an ACL injury on her period? Well, some retrospective studies on ACL injuries suggest that the relationship between an injury and that there is a relationship between the injury and a time of her cycle. But here's the problem. Not all these studies show the same thing. Some studies show that there's a greater frequency of injuries occurring around the follicular stage. And that's really the quote unquote, maybe the lowest hormonal environment. Some studies show a greater frequency in the late follicular phase, nearing the rise of estrogen and ovulation. Okay, so higher hormonal. While some studies show a greater frequency in the post-ovulatory phase. So that's in the second peak of estrogen. So estrogen is lower in the second half compared to the first. So if these injuries were directly correlated to hormones, why wouldn't the majority of these injuries all occur when estrogen was the highest? And a bigger concern is the question, are females so sensitive that a specific hormonal environment makes the participation in sport unsafe? And as just a species, how we've evolved to survive this long, that kind of makes you stop and think. So let's dive into this a little more. Another really big thing that we have to understand is that these studies have a big issue and that a lot of them depend on self-recall. That's saying to the female, hey, when was your last period? And a lot of times, just because a female is on oral contraceptive, she doesn't understand that that's not her period. That's something else we have to consider. Plus, now we have to understand that we are counting on females to remember exactly where she was in her cycle when she was injured. And that's pretty difficult, especially because remember, not every cycle is the same, and your hormonal environment is not going to be exactly the same with every cycle. So the truth is that these studies don't actually know the hormonal environment of the athlete before and during the injury. And I really think that this chart helps understand how different person to person fluctuations can be. Actually, on this next slide, you see Up on the top left, I have what the idealized 28-day cycle looks like, where the peak should be during certain days. And then next to it, you see 4 healthy women that are ovulating, that have a menstrual cycle. And you can see that each woman has different times when her estrogen peaked, when her progesterone peaked, when her testosterone peaked, and when she ovulated. So are females really at a higher risk of ACL injury during the follicular or pre-ovulatory phase? Or are we assuming that females are in this phase without actually knowing the hormonal environment? And that's important to understand. Okay, so to continue, of the studies in the 2006 meta-analysis that did show that there was an association between ACL laxity and the menstrual cycle, all 3 found that laxity increased during the post-ovulatory phase of the cycle. And now this is when there's a higher peak of progesterone and a smaller peak of estrogen compared to the pre-ovulatory phase. So this means that these findings on ACL laxity do not coincide with the majority of published findings that cite females experience more ACL injuries during the pre-ovulatory to ovulatory phases of their cycle. So again, we do not have conclusory evidence. There is some evidence shows that you're more lax during one phase, but your estrogen is higher during another phase. So can we say that estrogen or female hormones are the actual culprit? There's really so many variables. So let's talk about this. If estrogen and relaxin peak in the pre-ovulatory phase, then why does laxity show to increase during the post-ovulatory phase? And then why do most injuries, as we've seen, occur when laxity is reported lower? There could be a number of reasons. We don't really know the specific mechanisms through which sex hormones are actually impacting soft tissues and the potential for ligament failure work. Women have varied hormonal levels. This means some women can demonstrate alterations in laxity throughout the cycle, while others demonstrate little to none. Changes in hormonal concentrations that depend on the cycle may not consistently influence knee laxity. It's also possible that more injuries are going to occur when the ACL ligament is stiff, right, rather than lax. And the hormonal effects on issue rates may be more neuromuscular than structural. And athletes who experience menstrual irregularities and the consequence of these hormonal disruptions may actually be the heart of these studies, and we just don't even know. So you can see there's just too many variables. There's too many things that could explain the possible correlation, and there's not enough to make one theory stick. So maybe females really aren't as fragile as we thought. I actually bring up this, I found this research article to be really interesting because it was published in 2002, and they showed that through their research that they came up with the conclusion that most of the females in the study demonstrated that they tore their ACLs in the during or around ovulation. And they did do some type of hormonal testing, and it was really important because it makes you stop and question. So you can see that there's a table on the left-hand side, and they said in the data that even though these hormone metabolite levels were found to be within normal clinical ranges at the time of injury, the levels of all 3 female sex hormones were significantly higher during injury than on the first day of the subsequent next menstrual cycle. Okay, but does that mean that the hormones were higher before the injury or as a result of the injury? Because we know some studies show that estrogen is actually related to skin and any type of injury regeneration or recovery from it, right? Because estrogen is going to have a type of anti-inflammatory effect. So is that why estrogen is higher? Because of the result of the injury, or is it a cause? What came first, the chicken or the egg? Another really important part of this research is that although tissue remodeling is continuous, no doubt influenced by the mechanical and physiological environment in which it occurs, the factors influencing ligament repair after microinjury in athletes remains poorly understood. So again, we don't know if these hormones are higher and causing the injury or the result of the injury. And another big factor in this is that some of these athletes were on oral contraceptives, and if you actually look at the research, they said they cited a paper way back from like the early 1990s and said being on an oral contraceptive is not going to affect their hormonal environment. I mean, talk to Victoria Felker on that, but we all know that that's not really true. And then they discovered, because they looked at two different populations of female athletes, that the difference in estrogen and female sex hormone levels may have actually been related to age than anything else. So, but even with that, they still came out with what a lot of people read, and that's just the conclusions or the discussion. They said, oh, hey, yep, all these females tore their ACLs during this phase, but did they? And that really makes you stop and think. Because even if they did, does that just make females then innately more, predisposed to this type of injury because they're ovulating? Or why are there so many differences in the estrogen levels between, as they said, the skiers and the non-skiers? Oh, well, because there was a huge difference in ages between them, and maybe that's why the estrogen levels were different, and maybe the estrogen isn't the cause here. And that's really important when we start to look at these studies, that, yeah, this is a really important topic of conversation. Is going to become even more apparent, but not all research is as cut and dry and black and white as we want it to be. So is an athlete more at risk for an ACL injury on her period? Well, current science is starting to conclude what us females have kindly always known, and that it's highly unlikely that any negative effect on soft tissues is due to a single hormone, but rather represents a complex interaction among multiple hormones and other relevant factors such as an individual's genotypic profile and exercise habits. We can't generalize what's going on as a consequence of being female. Males and females all have different genetics, are in different sports, and train at different intensities. All of these factors may describe the extent to which a female is more susceptible to an ACL injury. Okay, so if a female stops getting her period, what does that mean to her ACL injury risk? We're going to touch on this because this is, again, a huge rabbit hole, but it's really important to bring up into conversation because it kind of helps you stop and frame how we look at female sex hormones. So the reason studying menstrual cycle disturbances is important on the ACL injury debate is that abnormal menstrual function or menstrual dysfunction is reported to be as high as 50% in exercising females. When we say menstrual dysfunction, this could mean that you're having 9 or few cycles a year. The female hasn't had her period before the age of 16, or she hasn't menstruated for 3 or more months, but she's not pregnant. So what's the cause here? This is a really cool chart that helps you understand that this is all, our hormones are related in that it's going to be affected by our hypothalamus and pituitary glands. And from there, that's what's going to stimulate how these different levels or cyclical nature of our sex hormones are coming about. So remember, sex hormones work together and do more than just prepare your body for reproduction. Estrogen plays a very critical part in bone formation, and the more time spent without adequate estrogen levels during growth for females, the lower their peak bone mass and lifetime bone density. Studies have reportedly shown how irregular menstrual cycles are associated with stress fractures. So, okay, we know that there's a relationship between bone injuries, but what about the ACL? Well, let's stop and think. Okay, theoretically, if estrogen and relaxin are the cause of ACL injuries in females, athletes who demonstrate menstrual irregularities and therefore have a blunted concentration of estrogen and relaxin should have a lower rate of injury, right? Well, the opposite is actually true. Some research suggests that the risk for severe musculoskeletal injuries may be somewhat higher in high school female athletes who experience menstrual cycle disturbances In a study on high school females in 2012, researchers cited females who experience menstrual irregularities, and they define that as 9 or fewer cycles per year, were almost 3 times as likely to sustain a musculoskeletal injury compared to athletes with normal menses. So if the theory was correct that these hormones were the cause, why are we seeing the opposite in females that have blunted hormones? So what does this actually mean is that your history of menstrual disturbances is actually likely to increase your injury risk. Studies have repeatedly shown that how irregular menstrual cycles are associated with stress fractures, and unfortunately not enough research on menstrual irregularities and ACL injuries really are out there. But a significant relationship we know does exist between musculoskeletal injuries, and this includes the ACL, low bone mineral density, and low energy availability. So are hormones the cause, or is it the depression of these hormones? With the new position on REDS and current research on the subject, it's actually really likely that low energy availability may be this confounding factor when considering the high cause of ACL injury rates in females. Even more, if nutrition is inadequate, females who sustain a musculoskeletal injury, such as an ACL injury, may also negatively impact their tissue's ability to rebuild. So if you stop and think about it, non-contact ACL injuries are an overuse injury. If more and more females are demonstrating a type of REDS or low energy availability, therefore they have less resources to recover. When you think of what an overuse injury is that over time we've exposed our body or our ligaments to more stress than they have the capacity to handle. And this capacity is lower if our ability to recover is lower. So if we're in a state of low energy availability, we now have a higher risk of injury. And we see that low energy availability is very high in the female athlete population. So maybe that's the confounding factor. We don't know, but that's, again, something to think about. Okay, so back to the original question, in that if hormones really are the cause of ACL injuries, can being on an oral contraceptive lower ACL injury risk? Okay, so if estrogen or relaxin can contribute and we take an oral contraceptive, that means that our endogenous production of our hormones is going to be blunted. So the results of a 2019 systematic review of the literature suggest the plausible association between oral contraceptives and ACL injuries are not so black and white. Of the 7 studies that examine the effects of oral contraceptives on the incidence on soft tissue injuries, only 2 concluded that oral contraceptives decrease the risk of ACL injuries, while 4 found the oral contraceptives have no effects. One study even determined that the oral contraceptives could increase the risk of developing a type of Achilles tendinopathy. So it's affecting the structural integrity of, just think about collagen. Additionally, one study observed no group differences in knee laxity and oral contraceptives, while another observed lower knee laxity in oral contraceptives. Various types of oral contraceptives have been reported to actually result in higher concentrations of markers of collagen synthesis and degradation, while other studies have shown that women using oral contraceptives show reduced collagen production in smaller tendon fibrils. So this just helps bring to light that there is such flawed research in terms of oral contraceptives. We have so many different hormone concentrations out there, and that this is really the biggest reason that we are seeing such various results. In a study that compared progestin-only pills with combined pills, so the combined pills are going to have both estrogen and progesterone, there was no significant difference between ovulation suppression and ACL injury risk. So again, if hormones were the culprit, wouldn't the suppression of these hormones and the suppression of ovulation result in less injuries? These studies say not so much. Okay, so to date, there is actually no strong evidence that oral contraceptives protect from ACL injuries. In these studies, there's just too many outlying factors. Like we discussed, there's different hormonal profiles, different types of OCPs used, think monophasic, triphasic, their duration of the use, the purpose of the use. Was the athlete, did she not get her period? Is that why she's on birth control? Did her doctor put her on that? Is that the confounding factor there? Again, we don't know. It's possible that the oral contraceptives may serve as a therapeutic role in decreasing sex disparity and ACL injury rates. But we need more research. We do know that taking an oral contraceptive is definitely not going to help influence low energy availability, which we know is a huge underlying problem in a majority of menstrual cycle irregularity in female athletes. So at the end of the day, oral contraceptive pill, that's not the answer. So here's the proposed idea. There's too many factors that are going to play into why females are experiencing ACL injuries at greater rates than males. There's just too many. But a big one that is important to understand is that females and males are different. We grow differently. Really great quote from the text, A Young Female Athlete. Unlike boys whose pubertal increases in testosterone aids in the accumulation of muscle mass, pubertal girls have difficulty building muscle, making joint control even more difficult. Okay, so if a non-contact ACL injury is an overuse injury, and we know that having a greater capacity to handle load is going to decrease the chance of experiencing overuse injury, males have a greater capacity because they have more muscle. So right then that helps us understand, okay, is that just the difference? Is this all it comes down to? And if it is, we know that strength training helps females develop lean tissue and strength. Larger amounts of lean tissue help females in two ways. These tissues help produce and absorb higher forces, meaning there's a greater dissipation of these forces when she lands. So from a physiological standpoint, a larger proportion of lean muscle leads to a higher failure point of the ligament. This means stronger athletes with a better body composition are more physiologically capable of withstanding higher loads on her body. So there it kind of is, right? A strong, lean tissue female has a lower chance of injuring her ACL compared to an athlete with a less muscular body composition. There's not a big difference between males and females. The benefits of strength training are going to go beyond physiology. Stronger muscles also means more efficient movements and joint stability. So when your muscles are stronger, your body is more adept at recruiting them for movement, such as landing or from a jump or decelerating from a cut. So studies suggest that females who strengthen their hamstrings in relation to their quadriceps have improved knee tracking and landing and deceleration movements, leading to decreased amount of force imposed on their ACLs. Okay, so strength training, we know, is the superior dose-dependent preventative measure for overuse injuries, such as non-contact ACL tears. So why aren't more females using them? To date, most female athletes are not provided these tools to the same degree as men. And in fact, the very meager amount of research at the female athlete level that is available cites that 50% of male athletes are required to engage some type of strength training, while less than 10% of females are required. And so at the end of the day, if it turns out that females are actually the cause, doesn't doing all we can to provide strength training, the one tool that we know helps reduce the chances of these injuries, doesn't that just make sense? So rather than continuing to debate on is anatomy the cause, is hormones the cause, because that's easy to pinpoint. Instead, if we just take a step back and look at the bigger picture, and that non-contact ACL tears are overuse injuries. An overuse injury means we've exposed the tendon, ligament, joint to too much force or stress than it has the capacity to handle. So what can we do to increase the chances of preventing these types of injuries? Increasing the capacity of the athlete. We have to do that through strength training. So maybe we have to start now having this discussion of why isn't strength training as available? How can we make it more available to females? And what can we do to convince more coaches out there that maybe grew up in sport, female coaches that may have grew up in sport that weren't exposed to strength training, how we get them to understand that this is something that is vital for female athlete longevity and health and the reduction of ACL injuries.